Good morning. Warm welcome to our IC on what's new in diagnostics. Evolution is something very important and integral part of our patient care. So, we have a great set of speakers who will be covering each specialty with regards to what is new. To begin with, I invite Dr. Pratheeba Devi Niveain, oculoplastic surgeon at MNI Hospital, to talk on 3D orbital imaging. I request Arul sir to please come on stage, please.
Very good morning. This is the same repetition for I think the speakers here, but anyways. So orbital fracture is not a very uncommon finding in our practice. So in patients with trauma and double vision, we should definitely ask for a health chatting, diplopia chatting and take a CT orbit to see for fractures. So very commonly we can see fractures like this with orbital fat entrapment and muscle entrapment sometimes, which definitely requires a treatment. So we were successfully managing orbital fractures since many decades with so many types of implant that is available in the market. So as in this patient where both anterior and posterior ledge is seen, we can very comfortably go ahead with surgery with a Med4 implant. In children with a white eye like this but a face turn and head tilt like this, children will not complain as diplopia, rather they will have a head tilt and a face turn, and the mother actually came up with complaints of face turn for this patient. We have to definitely take a CT orbit, and that shows a white blocked fracture. And in children, we prefer an osteomesh because it is biointegrable and that merges with the existing bone as the child grows. And in little more bigger fractures like this, and where there is a posterior ledge is not very defined, we put a titanium implant like this. So, but we had a lot of difficulties. We do not know the exact size of the implant, so we had to repeat the manipulation multiple times, and so there was more tissue injury which caused a delayed post-operative period, and there could be a wrong placement of the implant as well. So change is inevitable, and we have adapted changes in so many things, and 3D printed models are one such change which had happened in orbital fractures. They are nothing but they are molds to shape the implants pre-operatively, and that shaped implant is sterilized and used in the OT. So it's just an easy way of customization of implant. So how do we do that? So when we get a CT orbit, there is that's a format called DICOM format, and specifically we have to ask the radiologist for that, and that is with that format, the STL images, the 3D images are obtained, and the 3D model is designed. So the 3D model is designed like this, and once we get that, we can design our implant and plan the size and exact shape of the implant. Scenario 1, here there is a fracture in the right orbit. So they mirror the right orbit with the normal side, and we get the exact dimension of the fracture. So we get a model like this in the hand. So when we have the model in the hand, we can cut the implant exactly according to the shape and size of the fracture, and then we can autoclave and use it in the surgery next day. So in complex fracture like this, here the zygoma is fractured. So what the software does is it manually virtually reduces with superimposition, and then again it mirrors and gives STL image, and with the STL image we can get a model like this. So in this complex size of complex fractures also, we will know where all we have to put the screw, where we have to put the implant, and what type. Everything can be planned meticulously prior the surgery, and then we can go into the OR. So, and on top of this, there is something else called the patient-specific implant, like how we have the customized implant, like how we put the dough, take a measurement, paint. This is something called patient-specific implant. The previous things, we trimmed the implant, but in this, the company person trims according to the fracture size exactly, and so just we have to keep it in the place. And so what is navigation? Now, all these things are done manually. So we design, we cut the implant, and then we put it manually. But still, we do not know whether we are in the right place. So navigation will tell us where exactly we are inside the orbit. So it's just like a GPS tracker. It was started for neurosurgery, but however, that has come into orbital fractures because of its guidance, intraoperative guidance. It's been used for fractures and also for apical tumors, or the tumors which are very close to nerve. So we will know how close we are to the nerve. So that is the biggest advantage of navigation. Without navigation, sometimes we might go very close to the nerve or we might even hit the nerve. So in such tumors and fractures, it has been very commonly used, but people are now trying it for other surgeries like decompression, and even lacrimal surgeries are being done. So the navigation, in navigation, there is a software and the patient data is being fed, and then there is a tracker which says where exactly we are in the orbit. There are two types, electromagnetic, optical guidance. We follow the optical guidance, and the armamentarium has an instrument console which has the display, the pointer and the tracker. So as I said, it's a GPS tracker. So the patient data is fed, the registration is done, and we planned the procedure previously. And this is the setup, like how it is being done. I have a small video um, by Dr. Preeti, courtesy. So as you see in this picture, so this particular navigation, it gives us three images. It gives a coronal, axial and sagittal. So this is the pointer. So when we do the surgery, we will know where exactly we are, whether we have placed the implant right or we have placed the implant in the maxillary sinus. So it shows clearly where exactly we are. This has been done for a fracture, but it's very helpful in apical tumors because its predictability is very good. So advantages, lesser tissue manipulation, better and easy contouring of implant, faster rehabilitation definitely. But disadvantage is very expensive. It's equal the cost of a femto machine, I guess, the machine, I guess. So probably when we think about returns, we might not be able to get it in a single specialty center. It has a long learning curve and will need multidisciplinary approach. It needs a spacious theater to accommodate the armamentarium. So to conclude, adaptive technology in specific cases is very important, and a team approach, particularly when the fracture is complex, is very important. And this should not be forgotten. We should never forget this. We have to do a detailed visual field and an ocular examination before any intervention. That's more important than all these fancy technologies. Thank you. Thank you for the opportunity.
What data you have to send to the company when you do a workup?
Only they ask for the DICOM data. That we have to specifically tell the radiologist to give the DICOM data of the CT images. So then there is some technical person who does this STL models. So if we hand over that, they will give the model. So it's just like a skull model, that's all, nothing different. They mirror the abnormal side to the normal side. So we know we will have the fracture. Every நெஜத்துல fracture இருக்குமோ, we will have the fracture in that model. So now the people who have luxury of navigation can go ahead, but otherwise we can design the Medcore implant, we can cut the Medcore implant according to the shape and then sterilize it, and then we know correct and the implant can be placed.